It's December 1st, 2025. It's a big day in world events. In 1988, we had the first International AIDS Awareness Day. If we go all the way back to 1919, Nancy Astor became the first female member of British Parliament. Jan, I don't want anyone to say that we are ignoring countries that are not the US, but the thing that really stood out to me of all of the world events was actually in the US, 1955, because 12/1/1955 is the date that Rosa Parks refused to give up her seat on the bus, and it's often marked as a catalyst for the US civil rights movement.
Yeah, those are all really big events. And speaking of first female things, did you know that recently the first female umpire in an MLB game behind the home plate happened? So another kind of first female thing that happened more recently. But yes, obviously the Rosa Parks event is notable and interesting. I think as we start December, this is always the time of year where you think, what happened to 2025? This year went by so fast. I can't believe it's almost over. And then to me, December is the fastest month of the year because there's just so much stuff coming up at the end of it that you just end up speeding through it. It's like it never happened. So you got to kind of like put on the brakes and try to enjoy it while you can.
And Jan, we're going to slow down a little bit. Later this month, we have a little bit of a callback to some of our favorite segments from the year.
Yes.
We'll have our annual Rappies. We're actually taking a week off, so we are excited about that. Through the holidays, we'll have a little bit of a break. And then, of course, we'll be right back in January. But this is the first week of the month, and we've got a case. Jan, you have a really interesting case for us to get into, something that we probably see pretty frequently, but maybe we're not thinking about it exactly the way we should be.
Yeah, so let's just dive into it. Usually when you see pregnant patients, often we see pregnant patients in the ER, we clear them and they go up to OB, afterwards. These are, women in advanced pregnancy. But this case is kind of the opposite. I was on a shift, got a call from our OB triage area saying, we're sending a patient down to you. We had a 33-week pregnant woman come into our walk-in triage area, and she's complaining of chest pain and shortness of breath. Now she's 33 weeks pregnant, so we wanted to check her out. We did our ultrasound, we did an NST, we did our little stress test. She's cleared from an OB perspective. So we're going to send her downstairs to you for the chest pain and the shortness of breath. And I said, well, okay, that sounds fine. Do we need to do TOCO or ongoing monitoring? No, we've cleared her. She doesn't need any monitoring. Just do a workup of chest pain, shortness of breath. Okay, that's kind of interesting. So kind of a reverse triage downstairs. We get this obviously gravid woman. She's having a little bit of a hard time breathing, looks a little uncomfortable. She's working a little bit. Now she's 33 weeks pregnant, so she's also got, a reason to be short of breath. So you always have to kind of, remember what the normal physiologic changes of advanced pregnancy are. But, she did look a little short of breath. And so we have to, obviously we're going to take a step forward towards her and examine her. But as we do that, Swami, what are you thinking about this 33-week pregnant female, shortness of breath, a little bit of chest pain?
I'm going to have some assumptions that if the patient was kind of the normal shortness of breath for 33 weeks, OB probably wouldn't have gotten too much worked up about it. They would have just sent the patient home and said, yeah, this is normal. Like, this is what you expect at this point. I obviously want a full set of vitals and a good exam, but I think the thing we're all going to be jumping to is she's pregnant, she's short of breath. We got to think about pulmonary embolism. We know, especially in that third trimester, there is an increased risk for VTE. So that's going to be at the top of all of our lists. But we also have to think about things like pneumonia, pneumothorax. Could she be having an MI or like that SCAD kind of diagnosis that we've talked about in the past? Could she just be really anemic? Maybe she got some blood work upstairs. If she's been followed closely by OB, she's probably had serial hemoglobins over the pregnancy. So it makes it a little bit less likely. Could she have like a peripartum cardiomyopathy? Does that happen pre-delivery? I've only seen cases post-delivery. So I think all of those things are going to be entering our minds, but the vitals and the physical exam should narrow this down a little bit.
Okay, so her vitals, she's like mildly tachycardic. Yeah, like 100, 110, like around there. Blood pressure's fine. Her O2 sat's a little low, maybe 95, 96. We don't need to give her much in the way of supplemental oxygen, but, a little lower than normal. And she doesn't have a fever at this point. So we approach her, we're going to examine her. And what we hear on exam is some wheezing. And we ask her, do you have any asthma? Like, you ever had wheeze before? Doesn't have a history of asthma, never had wheezing before. So now I'm going to throw another curveball at you as you've got someone with new onset wheezing. What do you think about that?
All right, so could she be developing asthma at this point in life? I guess it's possible. All bets are kind of off during pregnancy. Things can happen, hormone fluctuations, et cetera, et cetera. But I think we also have to think about cardiac causes of wheezing. So could that actually be fluid in the lung interstitium causing wheeze? We can figure that out with a POCUS. That's a kind of easy thing for us to do to see if there's fluid in the lungs. Could this be an infectious process? Could she have a viral etiology causing some wheeze? Could she have a bacterial pneumonia causing wheeze? I think all of these things kind of jump a little bit further up. And then the other thing I would want to know, and it doesn't sound like this is what's going on, but does she have any upper airway noises? Is it possible that her shortness of breath is because there's some kind of an obstructive process? We know everything gets edematous during pregnancy, so there's no reason she can't have a little bit of laryngeal edema causing these symptoms. So those are kind of the things that I'm thinking of. I'm not too worried about that heart rate. We've talked about this, 100 to 110, pretty normal in third trimester of pregnancy to have a little bit of tachycardia. So nothing is really leaping out to me, but that's kind of my differential at this point. I think probably MI is a little less likely if there's a wheeze. Even PE becomes less likely if you're hearing wheezing, but I can't take it off of my list. So that's kind of where I am. Infectious stuff, maybe still PE, maybe asthma as a new diagnosis for the patient.
Yeah, that all sounds really good. And I guess I skipped also over a little bit of her history of present illness, like when did this start and how long it's been going on for. And it really started sort of the day before. She has like a little bit of nasal congestion, not much. No one else is sick at home, no fever, not really a cough, but just sort of feeling this a little bit of, just chest pain, vague, and then this just sort of trouble breathing. She hadn't even really noticed the wheezing. So in terms of the questions you raised, there aren't really any upper airway sounds. We don't think that's where it's coming from. And the wheeze just seems to be generalized. So, we jump to treatment. I think it's easy. You hear a wheeze, like, let's order some albuterol. Let's get her some therapy. Let's get her breathing a little better while we step back and think about this. And I think, one of the things we thought of is, should we do a chest x-ray or not? And we'll talk a little bit about radiation and pregnancy. Chest x-ray for me is an easy one. That's pretty low radiation. I would like to see the film to see what's going on with her lungs. So we order a chest x-ray with an abdominal shield, and it's clear. We don't see much on it. So I want to just start there. We've got a clear chest x-ray. We got the albuterol going, and now we're thinking about more diagnostics. What else would you order in this person in terms of blood tests, other tests?
I want an EKG for sure. We kind of skipped over it. I'm going to assume her EKG is going to be relatively normal. Chest x-ray, even though it didn't give us an answer, it does tell us like she doesn't have cardiomegaly. That is useful information for us to have. She at least doesn't have like a diffuse interstitial pattern or a focal pneumonia. So those are helpful too. I definitely want to do a cardiac and a lung ultrasound. Maybe I find that she's got a reduced ejection fraction, even though her heart is normal size. Maybe I find a pneumonia on the lung windows. Maybe we find a big dilated RV. All of these things could push us in different directions. So I'm going to get a POCUS. I would even consider looking at the lower extremities because my guess is she's 33 weeks pregnant. She probably has some lower extremity swelling. So maybe we get a POCUS down there too and see if she has a DVT, or I send her for a DVT study. And then in terms of other tests, like I'm probably going to get a basic metabolic panel. I'm probably going to get a CBC. I think I'm probably going to get a dimer here because she's relatively low risk, but she's not no risk. So I probably would add a dimer as well.
Yes. Okay. The dimer. Of course, we had a long conversation about whether to do the dimer or not. And I think it is a good case for a dimer. She is, basically there's some suggestion here, but she's relatively low risk. Now, the POCUS is a great idea. We did that. Didn't see anything in terms of heart, a low EF. Didn't see any fluid in the lungs. The lung POCUS looked pretty good. Nothing really. She did have a little bit of trace lower extremity edema. Nothing really there. So it didn't add a whole lot. But I think the dimer was definitely kind of our sticking point. We put it on there, sent it. And, when you do that, you have to tell yourself that if it's abnormal, I'm going to do the next thing, right? You have to like pre-commit to it so that there's not, a hard stop at the end of that. So dimer gets sent off. She's getting her albuterol. And so that dimer comes back. And what threshold would you use, Swami, in terms of what's your cutoff? How do you decide?
So if we go a little bit back in time in 2025, I think it was episode 18, Amal and I talked about the PE workup in pregnancy, how you probably can adjust your threshold for dimer. And the most accepted is using a year's protocol and doubling that number. There are kind of these ideas about adjusting the D-dimer based on where they are in pregnancy. I don't know how well accepted that has become, but I would definitely do a year's on this patient. And my guess is that would give me a threshold of 1,000. I think I would have a
Exactly.
threshold of 1,000 for that dimer, depending on what assay you're using, or 500. My assay is the lower cutoff, so 500 or 1,000, I double it. And then I'd cross my fingers and hope that that actually gives me a negative test. And then I can say, hey, listen, it ain't a PE. We can move on.
Yeah. So 1,000 is what we used, exactly right. We walked through the years algorithm. Remember, the years algorithm asked 3 questions. Do they have hemoptysis? Do they have a diagnosis other than PE that's more likely? And do they have clinical signs of DVT? Those are like the 3 elements of the years. So yes, the threshold is 1,000. And hers comes back just over, right? It's one of those ones where you're like, of course, like it's just over.
1,003.
Yeah. It's just like just a little bit over, enough where you're like, well, we're kind of stuck. And so now we decide, yes, we're going to go forward. We're going to get a CTPA. So at this point, we still have no explanation for her new onset wheezing. You're right. We could chalk it up to reactive airway disease and just being a viral infection. But, we're a little concerned. We don't want to miss a PE in this woman. So we're going to talk to her about a CTPA. Now, when you're going to order something like this, a CT in a woman of advanced pregnancy, tell me a little bit about your decision-making process. What kind of conversation do you have with the patient? Do you kind of formally consent them or just document that you have a conversation? How does it work in your hospital?
Yeah, I'll have a conversation and I'll document the conversation. I won't do like a formal consent, but I will put in the chart what we discussed and all that kind of stuff. Honestly, we know now that the risk of a single CT chest is pretty low. We don't really worry too much about it. So I'm not going crazy about telling the patient about all of the different things that could happen. I'm going to tell them, listen, if we miss a pulmonary embolism, that's really bad for your health. I don't have a better explanation for what's going on. This is the best way to do it. And the radiation exposure is really minimal. If you want, this patient did see OB. You could even call OB and be like, hey, this is the situation. The patient asked me to just touch base with you, make sure that you agree. They're going to agree. They're going to say, get the CTPA as well. So that can be kind of helpful backup if the patient needs a little bit more reassurance. The only thing that I would kind of I wouldn't put as a stop point, but I would consider is if I gave her albuterol and she felt better, that might be enough for me to not get that CT pulmonary angio. And Jan, I don't really have good data here telling us that if the patient feels better with albuterol, it's not a PE, but I think it makes it much less likely. So I would kind of consider, hey, she felt better with albuterol. This makes an infectious process much more likely for her. And then it's the question of, do I want to give antibiotics or not? We don't see anything on chest, all of these other questions to ask, but that might be the only thing that would push me away from the CT. But if she's like, oh, I don't really feel any better, I'm getting the CT, I'm going to have a conversation, and I'm just going to document that in my chart.
Yeah, that's exactly where I am. I agree. Just a little bit of a conversation advising that this is my recommendation and documenting that in the chart. Nothing more formal than that. Agree. So we do that. She says, fine, let's do it. We do the CTPA because at this point, while she is feeling a little better, which we're happy about, it just hasn't resolved completely. And the question is still lingering for us. So we send her for the CTPA. All right. So what does it show? Comes back. There's no yeah, right. There's no PE, but it shows a ground glass opacity consistent with pneumonia. So here we are with a CT diagnosis of pneumonia, and you're thinking to yourself, okay, I mean, that's fine. I'm good. I'm glad I have a diagnosis, but it just reminds me of how the chest x-ray is such a crappy test sometimes. I mean, right? Yep. I mean, like here you are with a diagnosis that you should, theoretically be able to make with a chest x-ray and a clinical exam and a good history, which we had done all those things and still end up getting a CT scan that shows pneumonia. So, what is the sensitivity of chest x-ray for pneumonia in your mind?
I know it's not very good. And I know it's not very good the earlier the patient is in the process. So this patient's had symptoms for a day. If they came in 4 or 5 days into their symptoms, I would think the chest x-ray would perform pretty well. I would say like in the 70, 80 range, but a day after, I'm not surprised. I've seen so many patients where the chest x-ray was negative, but their symptoms were so consistent with pneumonia, and either we had to get a CT for some other reason, or we're just like, I really think this is a bacterial pneumonia. I'm going to treat you. And then they actually end up coming back, getting an x-ray a couple days later, and they have a big infiltrate. So I'm not surprised that 24 hours after onset of symptoms, she has a CT diagnosis of a pneumonia, but the chest x-ray didn't show it. Now, the one thing is, and you said that your lung ultrasound didn't really show it, but lung ultrasound is better than x-ray. We know that. So in really skilled hands where you're doing this frequently, maybe you pick it up on the ultrasound and make that diagnosis, even though the chest x-ray is negative. I've seen this happen a bunch of times if you do it frequently, right? You got to do that ultrasound a lot to really know what you're looking for.
Yeah. And you have to be pretty thorough with it. In most cases, we're just screening for pneumothorax or just kind of taking a quick look and are not really doing a detailed, up and down type scan. So we had not seen it on the ultrasound, but admittedly, I don't think the ultrasound we were doing was really looking for that and wasn't as complete as it could have been. And so then we are at the end of our path here with a diagnosis of pneumonia. So of course, now we're going to start antibiotics. And then what's the disposition of a pregnant woman, 33 weeks, with pneumonia, who looks pretty good vital sign wise, but obviously, is high risk.
I'd probably keep her.
Yep.
I'd probably admit her to the hospital, at least for a day, just to see kind of how she does. I don't even know if you use something like a port score, if it would help you out here in determining, but she came into Kipnick. She came in uncomfortable enough that OB was like, I'm sending her down to you. I would think I would admit her to the hospital at least for a day just to be observed.
Yeah, so that's what we did. We ended up admitting her for some observation, also to kind of watch this wheezing to see if it came back. And, she did quite well. And, it just left me in the end feeling sort of like I had failed at some point, because how was it that it took me this long, all these blood tests, a D-dimer to diagnose pneumonia? And sometimes, though, that's just how clinical medicine is, isn't it? Sometimes it just, it's a twisty, curvy road to get to something that theoretically we should have been able to clinically diagnose, but people just don't come in all the time with typical things. And it turns out that it's not that uncommon to end up diagnosing pneumonia on a CT scan that you do for other reasons. That's one of the reasons we do CT scans, or the benefit of them is to find alternate diagnoses when we are in a place where we don't know what's causing the whole picture. And sometimes you find something that you didn't quite suspect. So the CT diagnosis of pneumonia is not a failure. It might be a failure of the chest x-ray. It's not a failure on your part. And you do find things on CT that help you.
I could not agree more. It's definitely not a failure. This is just how it is. And it would be great if the patient had more infectious symptoms. If she had a fever and cough, we wouldn't be having this discussion. You'd be like, yeah, you have an infection. Now, whether it's viral or bacterial, it might be a little bit harder to tease out, but I know you have an infectious process. But she didn't have those symptoms to kind of push you down that route. And we kind of know this, especially in young patients. They come in with pneumonia with often vague symptoms, right? Just a little nasal congestion, maybe just a little bit of a mild cough. A friend of mine had upper abdominal pain, and we found that he had a pneumonia, and he didn't really even have any respiratory symptoms. Now, he developed respiratory symptoms over the next 12, 16 hours, but at the time, he really didn't have them. So we know this happens in young patients. None of this surprises me. I think this is just kind of par for the course.
Yeah. And pneumonia can cause chest pain. And that's another part of pneumonia that we often go down a different mental route with chest pain, but pneumonia is on that list. And then also a reminder about, wheezing in general. Wheezing can be consistent with PE. That's not, that is not out of the question. Wheezing can also be consistent with pneumonia. And then you've got cardiac wheezing, as you mentioned. So not all that wheezes is asthma or reactive airway disease. Yeah. And also with that particular symptom or presentation, to challenge yourself to think about what's actually causing the wheezing. And not to just, sit back and give some albuterol and not think about where it's coming from. Certainly you can have a new diagnosis of asthma. It's possible, but what else could it be is important. We didn't talk much about the treatment of asthma in pregnancy, but the bottom line here is that it's no different than in non-pregnant patients. You don't need to withhold any of the particular medications. And so I think proceeding down the regular asthma treatment pathway is just fine to keep that in mind. And then also just, that chest x-ray isn't perfect. We already know that, but this case to me was a reminder that you may not see the infiltrate you're looking for, and you may end up finding it on that advanced imaging. You mentioned lung ultrasound's pretty good for this. Obviously, CT, excellent.
Fantastic. It's a great case, Jan. I think it's really good reminders of a lot of different things. The PE pathway in pregnant patients, how to diagnose a pneumonia, the fact that CT really does give you a ton of answers. This is just one more reason not to do a VQ scan. I already had a number of reasons not to do a VQ scan. The VQ scan would not have given you this diagnosis. It's very unlikely you would have gotten that information, right? So this is a good reason why the CT is there. You use it when you need to. Doesn't mean we should be throwing them around, but this patient clearly needed one to eliminate some dangerous diagnoses, and they did fine. So, great. This is a great case.